All right, I know people are still joining, but we also have a lot to discuss and want to respect everyone's time. So since it's 1 p.m. on the dot, I'll go ahead and get started. So welcome everyone who's joined so far, and please continue to introduce yourselves in the chat. This is our first community pediatric ethics education webinar. We're very excited to have you all here today. And this is being organized and sponsored by the American Society for Bioethics and Humanities Pediatric Ethics Affinity Group and by the journal Pediatric Ethicscope. I'm Amy Caruso-Brown. I'm the current, though soon to be outgoing chair of the Pediatric Ethics Affinity Group. And I'm very pleased to introduce our speakers today. We can go on to the next slide. Thank you. So our case will be presented by Dr. Jessica Zavadil and Dr. Kim Sawyer. Dr. Zavadil is a pediatric palliative care physician at Riley Children's Hospital at Indiana University, and Dr. Sawyer is also a pediatric palliative care physician and an ethicist at St. Jude Children's Research Hospital. We will have expert ethical commentary on the case following the presentation from Stowe Locke Teti, a clinical ethicist at Inova Fairfax Medical Center, and Dr. Jonathan Marron, who's a pediatric oncologist and bioethicist at Boston Children's Hospital, will be moderating the discussion. So at this point, I will turn it over to Dr. Marron.
All right, thank you so much. And I do want to echo Dr. Brown's welcome to everybody. We're excited to be starting this series, and we have an interesting and very thought-provoking case to start things off. And so if we can, so our plan for today is going to be in a couple of different parts. So first, Dr. Sawyer and Zavadil will be presenting the case around which will be the focus of our discussion. Professor Teti will then be providing us with some ethics commentary, and then throughout, I'll be helping to moderate some question and answer and discussion, which will certainly then continue after the ethics commentary. Please do feel free, in addition to continuing to introduce yourselves through the chat, to also provide comments and questions into the chat during the presentation and afterwards. Because of the Zoom format of things, I may be reading questions aloud, and depending on how our timing and things are working out, I may invite people to unmute themselves to read their questions, speak their questions aloud as well. For the sake of simplicity and and timing, please do put your questions into the chat first. All right. With that being said, now I will hand things. In a moment, I will hand things over to Dr. Zavadil and Sawyer. But one moment to start us off. We do know, based on learning science, that we learn things best that we hear first and last. So in addition to mentioning what these take-home messages will be at the end of our session, want to kind of set you up for them right now. So at the conclusion of today's session, I hope that people will be walking away with a couple of different messages. So one, even common clinical scenarios can be ethically challenging. That certainly is a message that we think that many of the cases in this case series will demonstrate. Two, that good ethics require good facts as a common tenet in pediatric ethics and in bioethics and clinical ethics more generally. Three, that shared decision-making is a core consideration in pediatrics and in pediatric ethics, but that, as many people are likely aware, true shared decision-making, particularly in pediatrics, is both complex and quite nuanced. And finally, clear, compassionate communication is really a necessary but not sufficient part of high-quality shared decision-making. All right, we'll come back to each of these in just a few moments. But that being said, let me pass the baton on to Drs. Zavadil and Sawyer to introduce the case.
Okay, good afternoon, everyone. So we chose a case that I think will be a clinical scenario that everyone is familiar with in their previous experience. And so we thought this would be a great way for us to kind of dig into some of the nuance and really look at shared decision-making. So our patient today is Sarah. She's a 28-day-old infant, and she's presenting to you with a fever. She has a temperature of 101.5. She's breastfed. She has not had any change in her feeding patterns or in the amount of wet diapers she's making. Her grandmother cared for her 2 days ago and now has rhinitis, but no other known sick contacts. In Sarah's pregnancy history, mom was a G1P0. Serologies were normal. Mom was GBS positive, but she did not receive any antibiotics during labor. She was delivered by a vaginal delivery with rupture of membranes for 5 hours. And in the family, all of her family members are in good health. On your exam, you find that Sarah still has an elevated temperature to 100.3 Fahrenheit. The rest of her vitals are reassuring to you. She looks well developed and well nourished. She sometimes cries, but she's consolable. She has a flat anterior fontanelle. Her TMs are gray. Her mucous membranes are moist. She has a cap refill of less than 2 seconds. Her breathing is non-labor and her lungs sound clear to you. Her abdomen is soft and non-distended. She has normal external female genitalia, and you don't observe any rash or bruising on her skin. So in summary, we have a 28-day-old term, well-appearing infant who's presenting with a fever in the setting of mom being GBS positive during delivery. So to review, this is the most recent algorithm from the AAP looking at how to manage well-appearing febrile infants. She falls in this age range from 22 to 28 days old. She's well-appearing. So the first step would be to obtain urinalysis, blood culture, and inflammatory markers. She does not have a positive urinalysis for the sake of this case. And when you check her inflammatory markers, they are not abnormal. And so this leads you to this decision point of may perform a lumbar puncture. And so the provider discusses the types of infections that Sarah is at risk for given her age, and recommends that a lumbar puncture be performed to rule out meningitis. However, Sarah's mom is scared about such an invasive procedure and declines this intervention. The provider is seeking guidance for reaching a mutual decision with this concerned parent. And just one more piece of information so that you have everything you need to work through how to talk with this family. When we look at meta-analysis, Sarah falls in the age range where there is a 2.6% average rate of invasive bacterial infection.
Thanks, Jessica, for sharing that case. And I think that this is an average over all infants, not necessarily taking into account her laboratory markers. So even that number is a little bit squishy and hard to know exactly how it applies to her. So this really feels like a case where, we landed on the algorithm and may perform an LP. And so how are we going to make that decision in light of what our clinical expertise is and what we might be concerned about, and especially in light of GBS positive, but it's been, 4 weeks and this baby has been well. How should we take all of this information and mom's real anxiety about a lumbar puncture into account? And so we would say that shared decision-making is really appropriate in this case. And shared decision-making is decision-making in which both parties share information and take steps to build consensus about the preferred treatment and reach an agreement on that to implement it. And in pediatrics, things get a little bit more complicated because usually we're not talking to our patient directly, we're talking to their surrogate decision maker, their parent. And so we need their informed permission, not just their consent for their own medical care. And shared decision making is really rooted in patient-centered care. We want to provide treatments that are most in line with the patient's values, goals, and preferences. And the ethical foundations for pediatric shared decision-making are really respect for parental autonomy and raising their children the way that they see fit. And it allows parents to protect the interests of their children according to their values. Legally, we also have this foundation of a right to bodily integrity. So medical providers shouldn't touch or intervene on a child without a parent's permission. And so we have all of these things that say that we really need to share decisions with parents, but we as providers also really have a duty to protect children as well. And sometimes we have a different idea than their parents about what might be best for a child. And so we have to balance those two views of what is best as we all work towards that common goal. And if you're looking for more resources about shared decision making, this is a really helpful supplement to the Journal of Pediatrics that has a lot of different articles about it. And we're going to be discussing one framework that was included in this supplement by Doug Opel. And he set out a 4-step framework for how to engage in shared decision making in pediatrics. And so this is what his framework looks like as a whole. And we're going to step through each of these 4 steps quickly. So step 1 is to say, is there a medical decision to be shared here? And in order for there to be a medical decision to be shared, we really need more than one option to choose between. So if there's only one medically reasonable option, we really need to discuss what that option is with the parents and recommend that the child receive what that therapy is. And here, medically reasonable means that this option meets the standard of care, which is to say that what most other physicians would do in a similar situation. And it's usually based on empirical evidence when it's available. And so we have to distinguish that from kind of standard practice, which is maybe what you typically do or what people in your hospital typically do. But we have to be careful that we don't conflict those two things, standard of care and standard practice. And so another example of this, in addition to kind of the case that we're dealing with, would be kind of a moderate acute asthma exacerbation. In that case, there's only one medically reasonable option. We should use a short-acting beta agonist and corticosteroids. That's kind of the only real medically reasonable option that we have in that case. And so we would recommend that therapy be given. But in our case, really doing an LP and not doing an LP are supported by our guidelines. And so in this case, we need to participate in shared decision making. So now that we know that we have a choice, step 2 asks, is there one option that has a favorable medical benefit to burden ratio compared with the other options? So based purely on the medical part of this decision, is one option better than the others? And that's because it's really our duty to protect this child and do what's best by them, mostly from a medical standpoint, at least as far as our part of this equation goes. And so we should be a little bit more guiding and clear whenever there is one option that's more beneficial from a medical standpoint. And so if that answer is yes, then that's going to lead us down to the left side of this diagram that says physician-guided shared decision-making. But really, if all of the options are equally okay, then we would land more in this parent-guided shared decision-making. So for Sarah's case, I would say that we would land more on that left side and physician-guided because we have good guidelines based on evidence, as far as we know the evidence, that we should consider an LP. And so that would be kind of probably where I would land in this case. But step 3 asks us, how preference sensitive are these options? Even if we are more physician guided, if a parent really feels strongly about this decision, and it sounds like Sarah's mother does, then we need to really take that into account. And so depending on how preference sensitive this option is to a parent, this may sway us kind of one way or another. And that's really because parents know their children the best. They can weigh competing family interests the best, and they're allowed to instill the values that they've deemed best in their children. And this step really asks physicians to be more involved than just saying, Mom or Dad, what do you want to do? It really asks us to dive in with this family and figure out with them, what are your values? What are your goals? How can we support them? Because many people haven't considered that, and they aren't sure, even if they are clear about their values, how it applies in this situation. And so we can be kind of in that figuring out phase with them. So in this case, sounds like we are landing in this physician-guided shared decision-making, but it's a highly preference-sensitive decision to this mother. So this would lead us kind of more towards a weak physician-guided decision. But if this was a mom that said, I just want to do whatever you tell me you think I should do, doctor, that would be a low preference. And then we landed kind of a weaker physician-guided. And the same is true even if we're in a parent-guided, depending on the preference level of the parents, that can be a strongly or more weakly parent-guided decision. And so step 4, you can see this continuum that I mentioned of strong or weak physician-guided or strong or weak parent-guided shared decision-making. And there's a few other things that we might need to take into account that help us adjust along this continuum. One would be the urgency of the decision. If we need to make this decision quickly, that might be more of a physician-guided. Whether the decision is a longitudinal decision that will happen over time, which will require more parent involvement, or if it's a single event only going to happen once. Also, if who's going to implement the intervention, is it going to be the parent or is it going to be the physician, can also take this into account. And so in our case, this LP is not emergent, but we do need to make the decision today. It's a single event and we're going to be implementing it. So that might make it a little bit more physician guided than we otherwise would if we could send a parent home to think about it. And if they were going to be enacting this decision. And so in this case scenario, we would land kind of in a physician-guided shared decision-making model that's a little bit weaker. We want to take into account mom. And so in this case, it'd be appropriate to really engage in conversation, figure out with Sarah's mom, what are your concerns? What are the things that you're most worried about? Is there an answer that I can give you factually that can reassure you about those things? And then let's work this out together. And it might be that we do decide to do the LP if we can be reassuring and persuasive. Or it might be that we decide together that actually, we have a lot of steps in place that we can safely send you home to watch if you still feel really anxious about this decision. So practically, these conversations can be really hard. And I know sometimes it gets my heart rate up whenever I go into these discussions, whenever we just don't know kind of what a family wants to do and they may already be upset. And so how can we practically make this happen with our families? And there's a few things really from my palliative care background that I think can be helpful even in these daily discussions. And one is really acknowledging emotions. And I would say this applies to our own emotions as well as to the parents' emotions. So I need to take a moment, realize my heart's beating a little faster. I can take a deep breath and figure out, why am I anxious? Is there anything that I need to do about that? Or do I just need to, be calm and be the calm source in the room to help this family address their emotions? And NURSE is a helpful acronym when you're thinking about addressing emotions. And this stands for name, understand, respect, support, and explore. So this conversation to address Sarah's mom's anxiety might sound like, I can hear how worried you are about Sarah and also about this lumbar puncture. I can only imagine how stressful this situation must be. As a new mom, you've only been home with her for a month, this would be really anxiety provoking. And you did exactly the right thing by bringing Sarah in to be evaluated. You're a really great mom. You're looking out for her. I'm going to do my best to ensure that we keep Sarah safe and that you feel really confident in the decisions we make together about her care. Can you tell me more about what you meant when you said that you were worried about the lumbar puncture? And kind of invite her to share a little bit more. And so that might be how you address that emotion. Another thing that we think about is in information sharing and using an ask, tell, ask pattern. And so sometimes we worry that people aren't following our recommendations because they don't understand what our recommendations are or why we're making them. And so we might need to speak a little bit more clearly about that. But sometimes families do really understand what we've told them, and they're making a decision that is different than ours because they have different values and we haven't unlocked that explanation yet. And so a way that we can be clear that someone has understood what our recommendations are and why, we can say, what do you know about, whatever this topic is, to understand kind of where they're coming from. Then we can address their specific gaps if there are any, or explain clearly kind of our thinking. And then at the end, we want to ask them kind of what they heard. And I know that I used to say, can you tell me what you understood from that discussion? And actually, sometimes families can be like, well, you don't think I'm very smart because you don't think I understood you. So one phrase that I really like that I've tried to incorporate in my practice is, sometimes I don't explain myself super clearly. Can you just tell me what you took from that so that I can make sure that I did a good job explaining? So we want to put the onus on us, even if we're like, that was a slam dunk, I know I did it right. That just invites that family in to feel like this is a person I can talk to. They don't think that I misunderstood. And kind of the final tip that I would say is these statements of I wish and I worry. And so these statements really help you align with the family while also maintaining that there might be a difference of opinion. And so for Sarah's case, you can see, I wish that I didn't want to put her through this procedure. Nobody wants to have their baby go through that. And I wish I didn't have to recommend that. And then you might follow that up with, but I worry that we might miss a serious infection and that Sarah could get more sick. And we would have missed this window when she's looking so well, when we could have started antibiotics and prevented her from getting very sick. And so that helps you really align with the things that you both want. You don't want to do this with Sarah. You don't want her to be sick, but it helps you share that, what you're worried about. And it can sound a little softer than making a prediction, because definitely sometimes we're wrong when we make predictions if we sound too certain about them, and then families hang on to that. And so this can be kind of a helpful way to be, again, humble in our communication, but also share what we're really worried about. All right, so I think that that's where our short case presentation ends. And we are ready to hear from our experts and also from you.
All right, so in a moment, I'm going to pass things over to Stowe to provide some ethics commentary. But I want to pause for a moment to see if there are any clarifying questions that people have, either about the clinical facts of the case, some of the psychosocial details, or any of sort of the ethics foundation that Dr. Sawyer has presented to us. So as a quick reminder, as a one-liner, this is a 28-day infant who was born to a GPS positive mother. She presents in the newborn period with fever, but the mother, as we probably have not uncommonly seen for many people who this is part of their practice, has expressed some reluctance and concern about the clinical team performing a lumbar puncture. Okay, so let's, I don't see any questions in the chat right now, but please feel free to put those in. And then I will pass the baton on to Professor Teti to give us some thoughts about the ethical frameworks and other ethical considerations.
Thanks, John. This case is interesting in that shared decision-making is something that both parties have to agree to. We talk a lot about shared decision-making, but what's actually being shared is an agreement with both parties to work with each other for the best outcome of the child. In this particular case, the language can also affect things dramatically. The words lumbar puncture are going to sound terrible to a parent who's not familiar with what that is. And so how we use our language, how we use technical phrases, how terms are couched can have a dramatic effect on the parent in front of you who's come in, may already be stressed, may not be stressed and feels like you're stressing them out. And so paying attention to the nonverbal cues that the parent has is very important. Simple things like always sitting down when a parent raises a concern, showing this is important to me, I'm taking you seriously. Making sure that the concerns that are brought up are addressed so that people never want to be made to feel stupid or to be asking questions that don't make any sense. And so part of the validating process, as described by Dr. Sawyer, is the kind of thing that can help build rapport quickly in these situations so that you can prevent matters from escalating. Now, if there was a situation, maybe if the patient was sicker than this and the provider didn't feel like this was something we could go without, it brings about another concern, and that's that medically reasonable is not an objective determination, right? Medically reasonable depends on what the goals are. And so sometimes there'll be a disagreement between the parent and the providers on what medically reasonable means. And in that case, we then have to work back to ultimately determining who has the authority to make these decisions for the child. Parents have broad discretion to make decisions for their children, but that authority is not without limits. And so the goal with shared decision-making is to keep everything in a space where we're working collaboratively together to do what's best in a situation that's generally tense, anxiety-provoking for the parent. And so things would only become worse if it were to become more of a confrontation. That being said, in some cases, we are obligated to press the matter further, to inform the parent that this might be something that just out of a duty of care to the child, we can't just send you home like that. In that case, if it does become a conflict, there are other frameworks we can fall back on that can come up in the discussion. John, I'll turn it back to you and open to questions.
Great, thank you. And so again, if people are thinking of questions, please feel free to put those into the chat. But I can start. So I'll direct this first question to you. You alluded to some of the unique considerations here and what would happen if, for instance, the clinicians thought that this was more urgent or more necessary. Just to bring it to a point, why is this different in pediatrics than it is were the woman, for instance, saying that she was reluctant to get a lumbar puncture for herself?
That's really the heart of the matter here. This goes back to a court case called Prince versus Massachusetts, in which a judge determined that parents did not have complete control over their children. They couldn't have their children do whatever they wanted just because they were their children. The court made a statement that's followed through the ages in bioethics, saying parents can make martyrs of themselves, but not of their children. And so ultimately, that's where this comes down to. Ethically, the child will live with the outcome of the decision in a way nobody else will. Whereas making a decision for myself, I'm the person who lives with that. It's not affecting somebody else. And I am the one who knows myself best. And while parents may know their children better than we do, they may not know their children better than their children know themselves. And they certainly won't have to live with the results of those decisions in the same way a person would themselves.
Thank you. That's really helpful. Sometimes people will refer to the idea of parens patriae, which is the idea that when thinking about children, there is an interest of the state in protecting the well-being of the child, and that alongside the legal case that Stowe referred to. Those are two things that we oftentimes think about, and why the setting in pediatrics is unique. There's a question in the chat, and I'll open this up to all of our presenters. So what are the ethical limitations on persuasion in informed decision-making? Obviously, we are working to convince the family to do the quote-unquote right thing, but what guardrails should exist in our efforts to informed or shared decision-making?
I would like to respond to that, John, and I would preface it by saying there's always a reason. In every clinical consult I have, I always begin by thinking there is a good reason why this person doesn't want to do what we're recommending. And my job is to try to figure out what that is. It may be they had a cousin who had a terrible experience with a lumbar puncture, right? That could be weighing in on their decision. And so in order to determine how far we push, we first have to understand what we're working with. And so if you're understanding that situation is going to determine what is appropriate to do. We don't want to be coercive. We don't want to scare people into doing things. We want to present, as Dr. Sawyer described, in the various methods of, we're worried about this, we're concerned about this. These are things that may happen. it's part education as well, as part of our duty of care, which comes from licensure physicians, licensure with the state. The state sort of empowers physicians to have this sort of oversight protection of parents. But ultimately, none of us have badges. The most we can do is appeal to CPS or whatever the authority is in your state. And then hopefully they will work with a social worker to try to come to a solution as amicably as possible.
I just want to follow up to that too, that I think that sometimes in, situations like this, and even ones where the distress is high from providers, I think that often leads people to come from a place of like, I have to convince them to do the right thing. And I find that it's helpful to approach from a place of curiosity, and really like coming in a humble, open place to understand, as opposed to coming to from a place of trying to convince.
I'll just add that this is a really interesting question that I think is still like a subject of debate among ethicists about kind of where is that line of persuasion and coercion. And so I love the examples that Stowe and Jessica talked about. And I'll say that there's still a lot of debate about kind of in a lot of different decisions, not just in pediatrics, kind of where does that line lie? Jennifer Blumenthal-Barbie is one of my favorite authors who writes about that. So I would look her up if that's something you're interested in reading more about.
I think the topic of shared decision making here is an interesting one, because we all talk about it in our practice, and it's something that I think most would say, yes, it's something that's we believe in, that we do. But even in the adult setting, which is probably more straightforward, I think it's still not clear exactly what shared decision making is and what it is not. And then it gets even more complicated when we're talking about it in the pediatric setting. Do our Stowe, Jessica, and Kim, would you guys state that somebody, a clinician, pushing back on a parent saying, this is what I think I want, or this is what I want for my child, is that still aligned with high quality shared decision making in a setting like this?
I think that would depend entirely upon the kind of relationship that had been developed. If there had been some rapport, if there had been that kind of give and take interaction, that's very different than someone who's shy, who's unwilling to speak up, doesn't, feels maybe that the doctors are the ones who should be in power here. And, so it's very much an interactive assessment. Some people are very outspoken, and you might be able to push back with them quite a bit. They may expect you to. Other people may not.
I think it very much depends on what all went before that statement, right? What are the conversations that you've had, and do you have a good sense of their understanding of the situation and it matching yours and the values and preferences that they're basing that on? Because I think sometimes also people make declarative statements about an outcome, and we don't understand all of their thought process that went into it, and we better understand their goals, in order to protect Sarah from a harmful procedure, because they perceive this to be really harmful because they've known of one person who's had a complication, and really like maybe that complication wasn't even from the lumbar puncture, it was, associated facts or contextual features. And so I think that understanding people's values and goals and being able to align our recommendations with their goals can be really powerful. And so I think it all depends on what are the other things that were said besides that kind of one declarative preference.
That's really helpful. I think what I'm hearing is that good open communication and rapport are really fundamental considerations in shared decision making and in the amount of back and forth that can take place as part of it. We have a couple of comments and questions in the chat. I'll get to those in a moment. We also have Yaram with a question. Yaram, please.
Thank you, John. Thank you, Kim and Jessica. Great case. And Stowe. I just want to circle back to what was already alluded to in terms of the limits of parental decision-making, but this notion of communication and how we phrase things. And it relates also to the limits of persuasion, manipulation, coercion. I think that we need to be very humble and keep in mind that even though a parent may not be making a decision that we agree with, they probably love their kid and probably still want what's best for that kid. They're just obstructed, let's say, and I just choose that word randomly, or challenged with a particular decision. And I think that's a very important place to put ourselves when we're having these discussions, because then we'll have a very different approach to these matters. And, you know, I think it's ethically permissible to do some gentle arm twisting. But again, that's very, I don't know necessarily that the relationship is as important in my mind. If I meet a new parent with a child with a cancer and I don't know them for more than an hour, I'm going to be making certain recommendations that they may not agree with. And I may strongly recommend something, but the manner in which I do that is important. So I think those caveats are worth recognizing.
Really nicely said. Thank you. Yeah, I think that even in that new relationship, being able to say something along the lines of, from what I'm hearing, you care deeply about your child and are looking for what's best. However, I worry that not doing the lumbar puncture in this case wouldn't be aligned with what you're saying. Let me explain to you why I'm concerned and why I do think that the lumbar puncture is in your child's best interest and will be aligned with what you're saying you're hoping for.
Exactly. And our job is to protect kids from the consequences of unwanted decisions, no matter who make them, their parent who loves them, or, you know, a bully or whomever.
Indeed. All right, so we have another question in the chat that from Ian Wolf. Would refusal of the lumbar puncture be allowed if the mother agreed, for instance, to admission for IV antibiotics? And along the same lines, how harmful is not getting the LP? Is this a reasonable negotiation, as it were?
I think this really gets at kind of why we chose this case, and it has a lot of small variables that you could easily modify that would shift the kind of way you'd move down that decision-making framework. I think it's important sometimes for us as providers to remember to do step one and assess if there's more than one medically reasonable option. And so based on the AAP algorithm in the case that we have set out, it would be reasonable to not do a lumbar puncture and to observe the patient and give antibiotics. And so that would be another medically reasonable option and something that you could discuss with the family. So I think you're really getting at the heart of what we were kind of thinking about as we designed this case.
And to push that a little bit further, what if, for instance, the child, instead of being 28 days, was 8 days? How would that change things? Or would it?
As the person who's closest to her pediatrics residency, I've been letting Jessica think most about this algorithm. I haven't done a lumbar puncture in a few years, but there are different algorithms for different ages in this recommendation. And so it very much depends on the age of the child. And yet even in this article, kind of especially in this 22 to 28 day range and the 29 to older day range, the authors really say that, you know, we have evidence that every week that a child is alive, their risk for a serious bacterial infection goes down. And we added these gradations. You know, it used to be that we said 28 days was the cutoff, and there wasn't this 22 to 28 day period. That's the way it was when I was in residency. And so they added in kind of this extra window to say that, you know, it's all a little bit gray. It's a sliding scale, and the physician's assessment of risk and benefit and the parents' assessment of risk and benefit and how risk averse or risk tolerant each of those individuals are will really play a big role in how you think about this case. And so I think that also gets to Jay's comment here that maybe this physician would be more in a strong physician guided. And that would be why I would actually still say it's appropriate to be more weekly physician guided, is because there's acknowledgement even in the evidence-based guideline that we have that says like it's a little unclear and there's some room for some wiggle room for your risk tolerance and risk averseness. But I think that wiggle room is especially in that 22 to 28 and a little bit older age period. I think less than that, we have more evidence that the risk is more serious. And so in that case, we may be getting to the point that it's no longer medically reasonable, appropriate to not do a lumbar puncture.
And so that final point that you were just making, Kim, I'll pose this to the group. Are all decisions expected to be ones that are shared, or are there certain situations in which the details are such or the evidence is such that a decision should not or might not be shared between the parents and the clinician in a setting like this?
I think, John, that the harm principle is what we would fall back on here. That a parent may not cause through action or inaction their child to be subjected to the immediate risk of a serious and preventable harm. And the two important qualifications there are generally immediate and serious, both of which are open to interpretation. And so the level for state intervention to override parental authority is pretty high. There may be quite a gulf between what is medically reasonable and what parents must do against their wishes.
If you don't mind, Stowe, I'll expand on this. I think this question comes up a lot when I talk about shared decision making, and so I actually put this slide at the end of our discussion, hoping secretly this might come up maybe, but this is just kind of how I visualize within Opal's framework how these related concepts like harm principle come into effect. And so to say that if we are not in a realm of shared decision making, if we say this baby is actually ill appearing or they are younger, and so this is not a decision that we can share, it's a recommendation that we need to make. Or if we have multiple options, but the parent doesn't agree with any of the options we're presenting them, then we're kind of on this other type of algorithm. And it really comes down to, actually, let me see. Sorry, we're on the wrong side. So if a parent's declining all the things that we say, then we get to the harm principle, like you said, Stowe, and that's by Doug Diekema, and he really says that there's these 8 tests that we should run this through before we call CPS or before we ask for a court order to compel a parent to comply with what we're doing. And so, right, is the child at significant risk of serious harm? What is significant? What is serious? Those are both open to interpretation, but probably more than 50% and probably like at least at the level of an inpatient admission might be kind of how I would think about that. Is the harm imminent? So it doesn't allow you that time to persuade or try less intrusive options before you get to it. Is the thing that we're going to do necessary to prevent the harm? And is our interference really proven efficacy? Is what we're going to do really going to protect the child from this harm that we're concerned about? And that what we're proposing isn't associated with similar risks of similarly serious harms. So it really is clearly beneficial, and there's no other alternatives. And that we would guard against bias, think about, would we do this for someone who looks like us, who our kids went to the same school, and we attended the same religious community, as well as like, would the public agree? Not that we necessarily need to air this in the public, but just like, would other people agree that this is kind of reasonable? So I think that I really find the harm principle and shared decision making related in this way. But I also think it's really important to be clear about when are we really sharing a decision and when are we being collegial and cooperative and supportive with the parent, but clear about whether we're sharing this medical decision or not. And I think that being clear in our own minds about whether this is something that there's a shared decision to make or not, really can affect the way we approach that conversation. It can help provide clarity to that parent too, whether they know that, we're going to have this discussion, but ultimately, like, I can't change my recommendation even if I want to, because it would be against my medical judgment.
And one important caveat, or I'm not even sure if it's a caveat, but an important point to be added here is that the OPA model for shared decision making really is but one model for shared decision making in pediatrics, and certainly there are other conceptualizations and other frameworks for thinking about how to apply this in the pediatric setting. The edition of Pediatrics that this was published in had a couple of other commentaries and other papers that alluded to slightly different ways of conceptualizing this. And the harm principle is also only one way of drawing the line below which parental decision making is deemed to be unacceptable or should be overridden, informing clinicians about when to look for court's involvement. Thinking about Loretta Kopelman's model of the best interest framework, or Lainey Ross's constrained parental autonomy model. Those are a couple of different ways of trying to figure out where to draw that line. And there's a great amount of debate about which of these is most appropriate.
I agree. I think they're all really, each of those different frameworks provide something that's really special and like helpful, that if we could conglomerate them all in some way, it would be useful sometimes. And I personally have found Doug Opal and Doug Beekema as clinically useful and relevant to me. And I happen to train with both of them. So that's probably why I lean on that, full disclosure there. But yeah, I think there's also, it's really helpful to read all these different frameworks too, if this is something you're interested in.
We're nearing the end of our hour. I do encourage, if there's any other questions or comments, people to put them into the chat. We do have an additional question from Vanessa Madrigal. How do we manage these decisions when the providers themselves disagree? For example, what if the ER physician is different from what the hospital says or different from what the infectious disease doctor says? This is slightly different and nuanced, and potentially powerful in influencing how we think about this decision.
I would say, just as a general principle, if the experts disagree, we have to give the decision back to the parents. I haven't come across a situation where that didn't apply. So that's my off the cuff response to that.
I also often think if so many experts who know all of the data can't agree, then that probably means there's more than one medically reasonable option. And so it's very helpful for us as a team to come together and make a unified recommendation, but also to realize that even if our unification is around a recommendation, it might still mean that the parent can have a reasonable, their opinion, and it could still be reasonably agreed with.
And it also brings up that point of remaining humble. I think when one provider or different providers kind of come in a much more confident manner and don't leave space for some of the ambiguity, then that can lead to a lot of distress for families and for the other providers involved.
I think this all relates to these questions of uncertainty and clinical uncertainty, which is a common issue in practice. Lynn Gillum's zone of parental discretion, which in some ways is sort of built off of Beekema's harm principle, tries to bring this into it and arguing that as the amount of uncertainty increases or the degree of agreement amongst the clinicians decreases, as our speakers have already said, that kind of pushes things a little bit more back towards parental decision-making or parental authority, and saying that, okay, well, if the uncertainty is great or the disagreement is great, we should lean even more towards accepting parental decisions and providing their authority. Any other questions?
Or comments. I've loved people's comments about normative ways that we talk and speaking about risks. If anybody wanted to voice those, I'd love to hear more.
I'll jump in there, Kim. I think it's super important that we be mindful of our own biases and even things as simple as how we frame percentages. And this isn't anything remarkable. I think we all know this, but just to remind ourselves that, if I say 70-30 versus 30-70, I'm already shifting how we think about it, just knowing the fallibility of human decision making and how we tend to prognosticate. And there's subtle things that we always decide to include or not to include because of if I had coffee this morning, or because I'm sitting across from, or any number of variables. And I think it's extremely helpful to, as we enter these discussions, recognize those and make sure that we're being honest and we're being as balanced as possible. And I don't know that it's ever possible to get away with all of our biases, but we certainly should make that effort. I think that's going to help shift this. And we need to own, and to John's point about uncertainty, I mean, I increasingly have become a little more comfortable over the years dealing with that uncertainty. And I will tell kids and parents, I don't know, it's not clear, this much I can say. And I think that can help foster that therapeutic relationship a little bit more. So some of these difficult decisions hopefully are negotiated, and there's nothing wrong with negotiation, negotiated a little bit more easily.
If I can piggyback on what Yoram said, it's been such a great discussion. I'm sorry I've been in and out because I'm on service, but thank you to everybody who's presenting and speaking. I think we also have to be very aware of our own emotional responses to how the parents are deciding these things. So I think one kind of cautionary tale that I think that I try to impress upon my trainees and remember myself is that, particularly in these areas of uncertainty, in these areas of gray, there are many of us who, despite that uncertainty, we have our own interpretations of the literature or our own ways that we've seen some of these, cases go before, to Yoram's point of our own biases. And if we don't, quote unquote, convince the family in the way that we think is right, often we think that we've failed. It's a very kind of interesting dynamic, and important to kind of take a step back and really look, really try to look at it as objectively as possible and to not take it personally if a family decides to go a different route. And as long as, it is in that kind of uncertainty window, not feel like you have failed as a clinician.
And I think coming back to the point of biases, it's important for us to recognize the implicit and explicit biases that we all have with regard to these conflicts between clinicians and patients and parents. I think there's a growing literature that demonstrates that clinicians in general, not just pediatricians, are more willing to go along with the preferences of those patients and parents who look most like them. And so we have to be very cautious about the bias that's quite explicit in that. And that there's unfortunately a history of CPS or DCFS being almost weaponized. And again, that whether that is related to these implicit biases or otherwise, that's certainly something that is worth having on our radar. All right, we're nearly at the hour, so I do want to make sure to give us a couple of moments to close and to tell people a little bit about future sessions for this series. So I want to first thank everybody for joining. This has been a lot of fun to be putting together with our team. And we have a couple of take-home messages that we really want to make sure that people have as they're going home. So one, even common clinical scenarios like this, an LP in an infant can be ethically challenging. For us to make good ethical decisions, we do require very good facts. So the facts of any given case are fundamental. Shared decision making, though complicated, is a core consideration in pediatrics and in pediatric ethics. But true, good, thoughtful shared decision making is not only complex, but it's very nuanced. And clear, compassionate communication is a really necessary and fundamental part of high quality shared decision making. So here's the contact information for Jessica, Kim, Stowe, and myself. Please feel free to reach out if you have questions or want to continue this conversation offline. And finally, this is just really the first session of what will be a recurring one. So for further information on this series, the Pediatric Ethics Education for Community-Based Practitioners Program, you can get more on the Pediatric Ethicscope page. That's also where the recording for this will be posted. And if you're interested and would like to send along a proposal for a future session, Amy Brown, who introduced this session, you can email her there and she will be the kind of one receiving those. There's a link for this also on the Pediatric Ethicscope page. So we look forward to having this be the first of many sessions. Feel free to reach out if you have questions, feedback, comments on this session or on future potential future sessions. And with regard to the future sessions, you don't, it certainly does not need to be something where you feel you have the answer. If it was a challenging case or is a challenging case that you're dealing with presently that you think would be a good one for us to discuss as a group, please send that along, and we'll be happy as a group to work with you on figuring out how best to present it and address the questions that it might bring up. So thank you all again for joining. Thanks again to Kim, Jessica, and Stowe for presenting along with me. Hope everybody has a good rest of their Tuesday and a good rest of their week.